Professor Deno, in turning to this three-drug protocol back in 1977, one of the things you've written is you said the law turned to medicine to rescue the death penalty. What did you mean by that?
By virtue of coming up with a method of execution that makes an inmate look serene, comfortable, and sleeping during the death process, by virtue of using a paralytic agent, the death penalty in this country was rescued. The humane application of a method of execution was a key goal, and the presence of doctors, their involvement, and the association with medicalizing the procedure enhanced its constitutional acceptability.
What does it mean to be not cruel and not unusual punishment?
This is what the petitioner was asking the court to do. Please provide us some Eighth Amendment guidance so states can know how to judge whether lethal injection is cruel and unusual punishment. So the court is in the position, or at least we hope, of answering this question. The Eighth Amendment has never said, nor have the petitioners ever argued, that executions are to be pain-free. The question is whether or not that pain is unnecessary, whether there are alternatives.
Chief Justice Roberts asked, do you agree that if the protocol is properly followed, that there is no risk of pain? And the attorney for the prisoners waffled, and I think he waffled because it's a medical question. And so I want to turn to both of you, Dr. Wiesel, Dr. Truog. What's your take on the answer? Is there no risk of pain with the three-drug protocol, if properly followed?
Define properly followed. In other words, the protocols list that this should happen and that should happen. But does that mean that if everything happens correctly, there are no problems with insertion of intravenous catheters, if there's no problems with mixing up the medications, there's no problem with delivering the medications, then yes, it would be pain-free.
I think I agree with Dave. You know, thousands of times every day people are getting anesthetics around this country. Many of them involve the use of paralytic agents. The risk of awareness under anesthesia is very, very small. It does occur, and that's the risk of the anesthesia being too light under the cover of a paralytic agent, and that's what anesthesiologists live in fear of that happening. Unfortunately, it occurs very, very rarely. I think the issue here is that people go to school for a long time and do years of training in order to be able to do this well. And certainly everything that I've read is that the adequacy of the training for the people that are doing it in lethal injection is nowhere near adequate.
So there is a practical empirical question, which is how likely is it that errors will occur with the current process of lethal injection? By one measure, there have been 40 clear botched executions out of a little over 900, which suggests a 4 to 5% rate of failure. But then, Dr. Wiesel, you started to talk about other problems that occur along the way, starting with drug preparation, where we've seen problems appear perhaps at an even higher rate. What's your sense of how often problems occur and what the problems are?
We have no idea what the error rate is because there's no oversight, there's no public reporting, so there's no way of knowing what's happening where. And the information you hear worries me that the process is of less concern. So for example, I believe the case was from Missouri in which they pushed the 3 jugs and the inmate didn't go to sleep. He was sitting there looking at them. And he realized the strap holding the arm was functioning as a tourniquet, not permitting the drugs to. So they loosened it up, all the drugs came in at once. Now in that case, I'm highly confident that the inmate experienced a great deal of pain from the potassium chloride. And yet, I believe it was the sheriff who was quoted as saying, no big deal. It's not like we hurt the guy or something like that. And so I think that your 4 to 5% number is dramatically underestimated. Second, I would argue that when we talk about medical error, we also talk about the consequences of if that medical error occurs. We should approach this with the gravest manner possible. And this should be done perfectly.
Dr. Truog, we're talking about you put an IV in, you give some medications. That's a routine kind of procedure that occurs thousands of times a day in any typical hospital across the country.
First of all, putting an IV in is not as easy as it may sound. Being certain that it continues to remain in the same place also requires actually quite a bit of experience, because these catheters can become dislodged, they can go into the tissue, and then they won't work anymore. Furthermore, we know that many of these inmates, by virtue of their past history of drug abuse or obesity or being muscular, can be very difficult to start IVs in. Now, in a hospital setting, we have a lot of different ways of approaching the situation when we can't get an IV in or it's going to be difficult. Most commonly, we'll just put in a central venous line. But there again, that requires a great deal of training, far beyond anything that would be readily available outside of the medical profession. The mixing, the administration of the medications, routine in any operating room in this country, but far from routine if you haven't done it before. And indeed, one of the mistakes that I know has occurred happened to me as an anesthesiologist early in my training, when I injected the paralytic agent too quickly after the pentothal, and they precipitated in the tubing. The tubing turned into a piece of concrete. Suddenly, I had no IV, and thank goodness I was surrounded by very experienced anesthesiologists who stepped in within moments, had another IV, fixed the problem, and it's never happened to me since. I learned my lesson, but I know that has happened in executions, and it could be a disaster.